woman and understanding how they're responding.
And based on that, then what's the value in doing blood work for assessing what their hormone levels are or where they're at in terms of treatment options?
Well, that's a great question. Blood work is quite controversial for perimenopause because the nature of perimenopause is that your hormones are going to be fluctuating. So there's a couple of situations where blood work is very beneficial. So if a woman has had a uterine hysterectomy, so she still has her ovaries, but she has no uterus, so there's no bleeding. So we have no idea how far along she might be, or if she has an IUD, or if there's been an ablation. So something where there's no actual period change to be able to inform us, is this woman in early stage peri, or is she like in full blown menopause? We actually don't know unless we get a couple consecutive FSH readings. So there's that benefit. There can still be benefit if you catch a elevation in a couple markers that can really help show us that they are farther along than we thought. But catching normal readings doesn't negate, we wouldn't really change our treatment.
Okay. Yeah, that was my understanding as well in terms of, not only is there going to be fluctuations, but it's also personalized. Like what one level might mean to you, like for you, might be different for another woman. So I think pairing it with symptoms, as you alluded to there, is like a must.
Oh, absolutely.
Yeah.
It is a must. But there is, I do say, like, there is value in doing an initial and doing a little bit of blood work, because there has been times where, again, the symptoms are telling us, okay, this woman is probably in very early stage perimenopause. She's still having a regular period. And then when we run an estrogen and FSH, her FSH is at a 20 and her estrogen's at like less, like in a menopause level. It doesn't mean it's not going to flip back on the next cycle, but it means, okay, you're getting those low levels. Like your body is farther into this process than we might have anticipated if we didn't.
Yeah. Thank you for that. The other component to all this is, I mean, if we look at why women weren't being offered hormone replacement therapy in the last 20 years, it's based on WHI studies. And what's your interpretation? When people bring this up, like if I'm going to take hormones, I'm going to be at risk of getting cancer. Like, how do you address that with your folks?
Yeah, that's a really important thing to address, because if women don't feel safe in what they're taking and they just feel dismissed, like, oh, it's fine. Again, the compliance is a problem, and you should always be able to ask these questions. So we know that with, dissecting this study up and down and left and right, the Women's Health Initiative, the average age of women was 65 in that study. It was primarily, it was looking at a lot of cardiovascular outcomes. The big part of what we saw with that, it was the synthetic progestins that played more of a role in the increased risk of breast cancer. The breast tissue is responsive to hormones, so there is this very slight increased risk if you are using hormones, especially on breast density, which can drop the ability on screening to identify a breast cancer. But the risk is lower, and people don't know that. The risk in using hormones is lower than alcohol consumption, not exercising regularly, being overweight. So there is, you must look at the entire environment in which we are putting, hormones in your body. So I often say the risk has been way over exaggerated and created so much fear, and women not having access to a therapy that can provide such an incredible, such a huge benefit. And they're leaning on things that increase their risk, like wine to sleep, and for the anxiety, and then they're not moving because they're too exhausted. So I'm like, at what cost?
And also, yeah, the opportunity cost, but also the trade-off of reducing your cardiovascular risk.